Large language models now match or exceed physician performance on medical board exams and diagnostic benchmarks. Yet in live clinical environments, these high-performing models frequently fail to improve the quality of care delivered to patients. This discrepancy is known as the model implementation gap. While models can now reliably process theoretical medical knowledge, their utility breaks down when they encounter the practical constraints of a real-world clinic. To understand how to bridge this gap, we have to look at Penda Health, a network of primary care clinics in Nairobi, Kenya. Their facilities manage high patient volumes and structural constraints that test the limits of clinical software. Penda's research demonstrates that utilizing modern AI in healthcare requires an implementation architecture robust enough to survive the friction of a live clinical workflow. The network rolled out an LLM-based clinical decision support tool across 15 clinics, tracking its performance across nearly 40,000 patient visits. This chart compares clinical error rates with and without AI support. In the history-taking column, the AI group saw a 31.8% drop in errors. This initial accuracy cascaded downstream. Diagnostic errors dropped by 16%, and treatment errors fell by 12.7%. Applied to Penda's full operational scale of 400,000 annual visits, those percentages correspond to averting 22,000 diagnostic errors every year. Replicating these results requires an analysis of the system's asynchronous architecture, behavioral telemetry, and equity governance. Early clinical AI tools often failed because they required doctors to actively type queries or click buttons to request feedback. In a high-volume clinic, that added cognitive friction led to low adoption. Penda addressed this by using an asynchronous architecture. Instead of waiting for a prompt, the AI operates as a continuously running background safety net. It relies on a specific trigger, activating silently the moment a clinician navigates away from a text field. By monitoring these exact inflection points in the electronic medical record, chief complaints, diagnosis selections, and medication orders, the LLM reads the documentation in real time. This zero-click integration provides maximum clinical coverage while allowing the clinician to maintain total autonomy over every decision. Frictionless architecture is a requirement for any clinical tool. If the software demands extra effort from the clinician, it will be ignored during high-volume shifts. This three-panel interface shows how the AI communicates its findings. It uses a tiered traffic light system to manage the doctor's cognitive load. A green checkmark confirms sound documentation, while a yellow bell indicates an optional advisory. The red state acts as a hard stop. It generates a pop-up requiring mandatory review for safety-critical risks, like prescribing antibiotics without clinical indication. Precise prompt engineering allows the system to trigger red alerts only for the most severe hazards, which prevents the alert fatigue that typically ruins decision support tools. A well-designed user interface only works if the clinicians actually change their behavior. Penda used behavioral telemetry to measure how clinicians responded when the AI fired a warning. Their primary metric was the left-in-red rate, the frequency at which a clinician saw a red alert but left the decision uncorrected. This graph plots the left-in-red rate over time. During the initial rollout, data revealed clinicians with AI access had the same error rates as those without. The flat trajectory during the induction period shows clinicians were ignoring the accurate warnings. Leadership initiated an active deployment phase, sharing comparative performance data with staff and using high-performing doctors as coaches. By holding staff accountable, the left-in-red rate for the AI group dropped sharply to 20%. As the study continued, this management focus produced a secondary effect. Clinicians began learning from the AI's logic. This chart tracks the started red rate, how often an error was made in the first place. That rate dropped from 45% to 35%, as clinicians began avoiding mistakes before the system even triggered. Clinical AI requires active management to be effective. Deploying the software successfully means tracking the telemetry and enforcing behavioral change on the floor. As these systems scale to thousands of daily visits, they introduce the risk of algorithmic discrimination. Preventing a model from scaling historical biases requires a human governance node. Nurses, acting as active data stewards, serve as the filter in this pipeline. One specific threat they monitor is label bias, where algorithms use a flawed proxy to determine patient priority. For example, if an algorithm relies on prior healthcare costs to determine clinical need, it can discriminate against marginalized groups. These patients often have lower spending because of systemic barriers to access, not because they are healthier. To correct this, nurses must capture social determinants of health in the electronic medical record, providing the LLM the context required to make a holistic assessment. Frontline staff act as the final check on health equity by design, identifying and correcting the invisible erasures built into large datasets through their daily documentation. With the operational mechanics proven, one technical question remains. How precise were the LLM's clinical judgments compared to human experts? In post-study evaluations, patient records were reviewed blindly by independent human physicians and simultaneously graded by advanced models like GPT 4.1 and o3. The results showed exceptionally high reliability. The agreement between the language models and the independent doctors on identifying clinical errors matched the agreement between two human doctors grading the same file. This data suggests that the base diagnostic capability of these models is rigorous enough to handle primary care workloads. The models are ready to scale immediately, provided the surrounding management framework is built to support them. The data from Penda Health suggests that bridging the model implementation gap is a solvable engineering and management challenge. Success relies on three specific pillars: an asynchronous interface, consistent monitoring of behavioral telemetry, and human-in-the-loop equity governance. Embedding NI into a high-volume facility necessitates a total restructuring of clinical workflows and a sustained focus on human behavioral change. Successfully integrating AI into healthcare relies on building digital safety nets that protect patients while training human clinicians to deliver more accurate and effective care.